Well, Joan Saddler is the co-chair of the NHS Equality and Diversity Council and Director of Partnerships and Equality at the NHS Confederation. She joins me now from Chingford. Obviously, all deaths from this virus are a terrible individual tragedy for families and colleagues, but there has been increasing concern about the disproportionate number of black and ethnic minority healthcare workers. You share it, I'm assuming.
Yes, I do share it, and let me first say I think it's great that we're now getting data from NHS England and improvement. We do need to work together on that data, and that shows the willing that we need to solve this problem. It's a huge, unexpected problem. It's a global pandemic, and we do need to work together with the data that we have.
I mean, that data seems to me to have been slow in coming.
Yes, and there's more that should be coming. What we do know is that we're now building on the data that we have. We know that the critically ill patients, we know that we're at least 34% represented in critical care. We're now getting data about deaths, and we still don't have data recorded of ethnicity on death certificates. So these are some of the things that we will be tackling centrally and must indeed happen.
That sort of information is surely needed critically if you're to prevent future deaths.
Yes, and for all communities, actually. This kind of highlights not just for BME populations, but for all of the population. If you don't have the data, then you can't solve the problem. And so there is something about not just having the data, but intelligently using it, because frankly, we know that BME populations are overrepresented when it comes to pneumonia, disease in some respects, 13% over the general population. And now we have a 34% critical illness in COVID-19 related critical care. So how do we use the data better that we have got? We need to start doing that straight away.
I mean, those numbers are so stark. Does the world of medicine have any idea why they're so stark?
Some ideas, but it's best not to start making things up. So we know that underlying health conditions such as asthma and heart disease, diabetes, BME populations will present at a higher level. We also know that outside of healthcare, there are socioeconomic factors reported by Michael Marmot in his report about socioeconomic conditions, but actually consultants, healthcare workers and nurses right across the scale of economics, some are paid very well and some are not. So this isn't just a simple correlation, and we do want to get to the bottom of a disease that really is quite frightening.
As you say, it is right across from well-paid consultants, but there are a number of very low-paid healthcare workers who, I think, up until now, will have felt that many people viewed them to be low-valued, that term low-skilled. Do you think this changes any of that?
I think it must. The low value, the hostility that BME people face, and they do day to day, the reality of the microaggressions we face, the staff who will report in our workforce race equality standard reports that they face more discrimination and harassment. These are realities, and we do want them recognised. We want the anxiety recognised for the whole population, but more so for BME staff who are on the front lines and scared that they won't go home. This is not acceptable.
So much more to talk about, but Joan Saddler, for now, thank you very much for